Uh, Good evening, everyone. From people who join from East, and people, good morning and good afternoon, people who join from the East. I would like to welcome everyone for our webinar from PHA, Planetary Health Academia, today. Now, we are really honored to have our distinguished panelist and chairperson. Our chairperson today, I would like to introduce everyone very briefly, and we are very excited to have our speaker and an exciting session. So today's the topic is what's your diagnosis? Case-based visual vignettes. We are honored to have Professor Rubina Yasmin to chair the session. She is Professor of Medicine and currently ADG, Director General of Medical Education. Dr. Anindita Ahmed, she is a hospitalist at Methodist Hospital, San Antonio, USA. She will co-moderate the session with me. Now, our speaker today is Dr. Farzana Haq. She is an Associate Professor of Medicine, Active Internship Director, St. Louis University School of Medicine, and also Medical Director, St. Louis University Hospital. We are honored to have our panelist, Dr. Fraz Mir. He is consultant physician in acute general internal medicine and clinical pharmacology and therapeutics, and Cambridge University Hospitals, Associate Dean, University of Cambridge, UK. Our other panelist, Professor Dr. Muhammad Abul Kalam Azad. He is Chairman, Internal Medicine. He is also Pro Vice Chancellor, Administration, Bangladesh Medical University. Professor Muhammad Munir Uzzaman, he's professor and head of department, Department of Medicine, Mugda Medical College, Dhaka, and convener, Bangladesh Society of Medicine. Member, Educational Activities Committee, Bangladesh Medical Research Council. We also have Dr. Muhammad Shahbul Huda Chaudhuri. He is Associate Professor of Medicine, Dhaka Medical College and Hospital, Member Secretary, Subcommittee, Bangladesh Society of Medicine. We have Professor Dr. Muhammad Azizul Haq Azad here. He is Professor of Medicine, Rajshahi Medical College and Hospital. Professor Dr. Muhammad Shafiqul Bari. He is Professor of Medicine, Dhaka Medical College and Hospital. And Dr. Adnan Chaudhuri, he's Assistant Professor of Medicine, University of Missouri, Kansas City, USA School of Medicine, Truman Medical Center. Now, we are very excited that our academic partner today is Bangladesh Society of Medicine, and our scientific partner is Incepta and United Care Hospital. So I would like to invite Dr. Farzana Haq to present the clinical vignettes. And before that, just some housekeeping that she is going to present the vignette, and after each vignette, she has some questions. There will be some options for the answers, and please, audience, put your answers into the chat box. Dr. Anindita Ahmed is gonna keep a close eye on the chat box and will let us know which is the majority picked the answer. Now, if you have any question regarding that vignette, just please type it into the chat box as well. Dr. Anindita Ahmed is gonna look into the chat box, and if there is any questions, she is gonna ask our speaker and the panelist. And then we are gonna invite one of the panelists to make any remark, and then we are gonna move to the next vignette. So without further ado, Dr. Farzana Haq.
Thank you so much, Dr. Mitro, and thank you everyone for joining us today. Your presence truly makes this session meaningful. Today we will talk about what's your diagnosis, case-based visual vignette. If you are a fan of Feluda Goindagiri from Satyajit Ray or maybe Sherlock Holmes, you know that all these detectives, they are looking for visual clues, and then they're coming up the solution of the problem. You, me, all of us, we are kind of a medical detective as well, because when we are collecting history, physical exam, all these are giving us clue, and then we are having the diagnosis. So all of us, we are a medical detective. So that being said, we will take a short journey today to foster our visual diagnosis skill through interactive case-based approach. And here we will have cases from variety of organ systems. Our goal is to explore evidence-based best practices that we can bring at bedside to optimize the patient care and outcomes. So let's see what will be the roadmap of this session. We will analyze 6 clinical cases that resemble our daily practice. And we will learn key points from each case to ensure timely diagnosis and management. And Dr. Mitro mentioned that after each case, during that time, we will have interactions, our approaches from all of you, our audience. Then I will go through very few key points, and then our respected one of the panelists, they will share their expert opinion after each case. So let's first start with our first clinical case. This is a Mr. A. He is a 49-year-old man who presented to your emergency department. He has weakness on the left side that had developed just 40 minutes earlier suddenly. An ischemic stroke in the territory of right middle cerebral artery was diagnosed by you, and you initiated tissue plasminogen activator or thrombolytics. Just after 3 hours, you got a call from the nurse because now the examination is showing the change in the patient's tongue. He was not on any ACE inhibitors. And now here is the patient's tongue. The question is, what is the most likely diagnosis? Is it tissue plasminogen activator associated angioedema? Is it lingual artery thromboembolism, lingual dystonia, or unilateral hypoglossal nerve palsy? We will have around 30 seconds to encourage our audience participation through the chat, and then we will move ahead.
I think someone said number 4.
Number 4, okay.
Let me check.
Thank you.
Well, let me check. We have a few more answer. I have one. Okay, 2 said 4, 2 said 1.
Fantastic. Thank you. And again, truly appreciate your participation. That truly the essence of this interactive workshop. So let's see what is the correct answer and why.
1 said 2. Okay.
Thank you. So the correct answer is 1, tissue plasminogen activator associated angioedema. And let's see why is that. Orolingual angioedema during or after thrombolysis for cerebral ischemia, it has been well published. And as you can imagine, this is an airway emergency. And our patient got treatment with IV antihistamine and glucocorticoids without, fortunately, no airway management. His tongue swelling resolved within 24 hours. He was diagnosed to have orolingual angioedema due to tissue plasminogen activator. Orolingual angioedema, this is a life-threatening airway emergency that typically occur within first 4 hours after TPA administration. Treatment includes IV antihistamine and glucocorticoids, advanced airway management if required. If you remember just one thing from this case, that will be orolingual angioedema is a potential adverse effect of TPA, particularly in patients who take ACE inhibitors. However, important to notice that our patient was not on ACE inhibitor. So it can also happen if the patient is not ACE inhibitor. So I will invite our one panelist to share their expert thought before we proceed to clinical case 2.
Wait, Shandon. I remember you. You went to the gay furry group meetup. Wait, do you remember me? Do you remember me?
Yes.
Oh,
Nice to see you again.
I would like to invite Dr. Azad to talk about this clinical scenario. If you can share some thoughts, what should be the next step and what do you think about this case and then how we should manage. Dr. Azad?
Assalamualaikum.
Waalaikumsalam.
Waalaikumsalam.
Thanks a lot. This patient presented to with the complaints of the stroke, and she was treated with plasminogen plasmid activator, and they developed angiolytic edema, like just swelling of the face and lingual swelling. So we already mentioned that patient was not on an ACE inhibitor. So this is a rare entity. This can be happen in clinical scenario, but this is very rare entity. So treatment, you already prescribed that, you are stopped the drug, already given, antihistaminic is given, steroid is given, and we can prescribe the norepinephrine and noradrenaline can be a very good choice in these cases. And that's adrenaline can be a very good choice. And there's some sort of other drugs, that is one is steroid inhibitors, that is the Calibant and ecallantide. We can use these drugs also. This can be an alternative medicine. But this is a very rare entity, I think so. This is very rare condition.
Thank you, Dr.
Thank you so
Azad.
much.
Appreciate your thought. Now we will proceed with our second clinical case. This is Mr. B. He is a 29-year-old man with celiac disease, presented with a 2-year history of intermittent episodes of throbbing occipital headache associated with blurred vision lasting for a few minutes to an hour. Had a 10 kg weight loss over 6 months and had seizure episodes 2 days ago. He had been treated for migraine with little response. Lab revealed mildly decreased folate, and CSF studies was unremarkable. CT scan of the head revealed bilateral occipital calcification. So this is the CT scan you are seeing for this young man. The question is, what is the most likely cause of cerebral calcification? Is this blastomycosis, celiac disease, Fart syndrome, or hypoparathyroidism? So this is the CAT scan, and these are the options.
excuse me, doctor. I have a question.
Yes, please.
So when wait, sorry. I just had some lines. Wait, whenever I bust a fat nut, like it comes out red.
I did not catch you.
একটু বের করে দাও তো ইয়ে থেকে মনে হয় ইয়ে ঢুকছে হু ইজ দ্য
Okay.
ইয়ে কে এখানে অ্যাডমিন কে
Dr.
Admin-
Mitro and Dr. Anindita.
So I
have
think
moved him.
yes, I let Viva know to kick him out of the session. So I don't know.
Sir, I have removed him.
Okay,
you.
thank you.
Thank you,
Viva. Thank you.
Viva.
Thank you.
Okay, so
let's
most of
add
the
back on.
yeah,
Mhm.
yeah,
Yes,
most of the
let's-
participants actually answered two.
2? Okay, fantastic. Thank you. Yes, so the right answer is celiac disease, and let's see why. So this has been published in New England Journal of Medicine, occipital calcification and celiac disease. And this is a very interesting syndrome, CEC syndrome. The CEC stands for C for celiac disease, E for epilepsy, and last C is for cerebral calcification. Folate malabsorption is the key mechanism for cerebral calcification here. And cerebral calcification can also be seen in other conditions related to folate deficiency, such as when our patients are getting treatment with methotrexate and also congenital folate malabsorption. If you remember just one thing from this second case, folate malabsorption can cause cerebral calcification, such as celiac disease. I will now invite one of our expert panelists to share their few points about this second case before proceeding to the third clinical case.
Thank you, Dr. Farzana. It's a beautiful case.
Thank
In
you.
fact, whenever we deal with a patient with neurological symptoms in a patient with celiac disease, we have to consider CEC syndrome. And in this case, there's a complete form of CEC syndrome because this patient has features of celiac disease that is manifested as weight loss, has epilepsy, and also cerebral calcification. The most important differential diagnosis in these cases is migraine, but this patient was treated with anti-migraine therapy, but with no response. Other DDs are Starch-Weber syndrome, but this patient had no features of port 1 stain, and there is no history of cranial irradiation or interthecal methotrexate. So all of the differentials are excluded. So these patients actually present with focal seizure, which may become secondarily generalized. And most of the cases, the seizure responds to carbamazepine, but in some cases, it can be drug resistant. So the CT scan can differentiate the cerebral calcification of CEC syndrome from cerebral calcification of Starch-Weber syndrome because in CEC syndrome, the calcification occurs in the parieto-occipital region in both the cortical and subcortical areas, and there is no associated brain atrophy. And after giving contrast, the calcification does not enhance. But in Starch-Weber syndrome, the calcification is mostly cortical, and there is associated cortical or lobar atrophy, and the contrast, after giving contrast, it enhances intensely. In this way, we can differentiate these two. But these are pretty rare. CEC syndrome was actually first diagnosed in 1992, and it's a relatively new case. It's a beautiful case. Thank you very much.
Thank you so much for your expert input. Sincerely appreciate it. So now let's move forward with our third clinical case. This is Miss P. An 83-year-old woman presented with a 3-week history of new dyspnea and dry cough. Temperature 36.3 centigrade, oxygen saturation 78% on room air. Your examination is remarkable for inspiratory crackles in the upper lung field, no JVD or edema. Your lab showed neutrophilic leukocytosis, no eosinophilia or LFT elevation. She had been taking nitrofurantoin daily to prevent recurrent UTI for last 5 months. You ordered a sputum culture and viral respiratory panel. Both of them came back negative. Then you ordered chest X-ray and CT chest. So let's see what the chest X-ray and CT chest is showing. So this is the chest X-ray and CT chest. Definitely, it's not normal. That we can conclude for sure. So the question is, what is the most important element of the management of this patient? First, antibiotic and IV Lasix or IV Lasix. Third, bronchoscopy and cessation of nitrofurantoin. Or fourth, cessation of nitrofurantoin. I will again appreciate your participation in this third clinical case.
Okay, I'm seeing number 3, 4. Let me see.
Okay, thank you, Dr.
One said
Vinita.
4, one said 3 so far. Let me
Okay.
check more. 3. I think 3 is the most common answer. Yep.
Fantastic. Thank you, Dr. Ahmed. Okay,
Mhm.
so yes, the right answer is 3. And let's learn a couple of key points from this case. First, let's take a look at our patient. She had this imaging finding long-term nitrofurantoin, so a diagnosis of chronic nitrofurantoin-induced lung injury was made. Nitrofurantoin was stopped and prednisone taper was prescribed. And let's see how is the imaging finding 2 months after cessation of nitrofurantoin. As you can see, it's like almost remarkably better compared to the previous chest X-ray and CT chest. So chronic nitrofurantoin induced lung injury it could be leading to fatal ARDS. So it is very important when we are prescribing any medicine, particularly to our geriatric patients, always need to review the medication list. Couple of key points for chronic nitrofurantoin-induced lung injury treatment. 3 things need to be implemented immediately. First, immediate cessation of nitrofurantoin. Second, documentation of nitrofurantoin as an allergy, because there are a couple of studies done that has been shown that if these patients are getting nitrofurantoin again, their lung injury would be much more severe than the first time. And third, instruction to avoid nitrofurantoin immediately to these patients. If you remember just one thing from this third clinical case, that is nitrofurantoin associated lung injury is a diagnosis of explosion. And that's the reason, in addition to stopping the nitrofurantoin, the bronchoscopy needed to be done to rule out any other pathophysiology. So now I will invite our one respected panelist to share their thoughts before we proceed to fourth clinical case.
Hello, I'm Professor Manoj.
Hello.
Hello. Nitrofurantoin-induced lung injury, fortunately, is a rare but potentially serious and often life-threatening complication of the antibiotic nitrofurantoin, which usually we commonly use for urinary tract infection. And nitrofurantoin-induced lung injury can be of acute, subacute, or chronic type. And acute nitrofurantoin-induced lung injury develops within hours to weeks, and in most cases after exposure to first dose. And chronic nitrofurantoin-induced lung injury develops after continuous use of nitrofurantoin for more than 6 months. And acute nitrofurantoin-induced lung injury may present as shortness of breath, cough without production of sputum, and occasionally with fever, rash. And chronic nitrofurantoin-induced lung injury may present with insidious onset of cough, sputum without cough without sputum production, shortness of breath, and usually not associated with fever. And usually blood report shows no eosinophilia, but in acute injury, acute nitrofurantoin-induced lung injury, there is eosinophilia, and it is a type 3 hypersensitivity reaction. But chronic case, it is directly caused by cytotoxic injury and reactive oxygen species. And it is a high degree of suspicion is essential for diagnosis because it mimics other lung condition like heart failure or pneumonia. And for those situations, you just stop the antibiotic, what you did in this case, and supplemental oxygen is in most of the cases is sufficient. Occasionally, patient may need steroid support, though the role of steroid is controversial. But when there is fibrosis and when there is inflammation going on, steroid definitely helps. And acute nitrofurantoin-induced pulmonary toxicity is usually reversible, and in most of the cases, these are reversible, but occasionally there is residual fibrosis. So whenever we suspect nitrofurantoin-induced lung injury, diagnosis is made by exclusion of other conditions mimicking that situation, and treatment is withdrawal of the drug and occasionally steroid, and labeling nitrofurantoin as allergy, and indefinitely this nitrofurantoin should not be used in this case. Thank you. Thank you.
Thank you so much, Dr. Morujaman. That's such a very much wonderful insight. Truly appreciate it. Now let's focus on our fourth clinical case. This is Mr. K, who is a 64-year-old man who has a history of mitral valve prolapse and Hodgkin lymphoma for 25 years, came to the ER with a 5-day history of dyspnea. You did physical exam, it showed JVT, a holosystolic murmur at the cardiac apex, and diminished bass sound in both lung bases. Then you ordered chest X-ray. And here is the chest X-ray. So now the question is, what is the next best step regarding this right lung opacity? First, should we collect a sputum culture and start empiric antibiotics? Second, diagnose this patient and obtain a repeat chest X-ray. Third, should we obtain a CAT scan of the chest? Or fourth, perform a bronchoscopy? So again, for your convenience, here is the chest X-ray, which is showing the right lung opacity.
I have 1 and 2. One said 1 and one said 2.
Okay, thank you.
Let me see. There is another. So 2 said 1, 1 said 2. So
Okay,
most of the people, well, now 2, 2.
okay,
2 and
okay,
2. 1 again.
okay,
I think most of the people answered 1.
okay. Thank you.
And
Appreciate
then
it.
1 said 3.
Okay, wonderful. And that is actually very much important, that where we are sharing our first intakes, and this way we can rule out that, okay, why this is happening and why not. So thank you so much, all of your participation. So let's see what is the right answer and explore the key points from this case. The right answer is diagnose the patient and obtain a repeat chest X-ray. So let's see what happened for our patient. As you can see, this is the chest X-ray on presentation with the right lung opacity. And after diagnosing, on the right hand side is the patient's repeat chest X-ray. The right lung opacity is completely gone. So what is the diagnosis here? This patient, after got the IV Lasix, the chest X-ray was done, it showed resolution. And this is the diagnosis of phantom tumor of lung. Phantom tumor of lung, this is widely published. It has been published in multiple reputed journals. And this is also called vanishing tumor or pseudo tumor because it disappears with the diagnosis, like for our patients. And then why this is happening? This is happening due to localization of the pleural effusion within that interlobar fissure during exacerbated congestive cardiac failure. So if you remember just one thing from this fourth case, that is the phantom tumor of lung results from localization of the pleural effusion within an interlobar fissure due to exacerbated congestive cardiac failure. And it is very important to have this differential in our mind. Otherwise these patients can get like CAT scan and a lot of other maybe invasive procedure. At the same time, if we are aware about this diagnosis and it match with the clinical setting of exacerbated CHF, we can provide right diagnosis and can optimize the patient outcome. So now I will invite our another wonderful panelist to share the thought on this case before we proceed fifth clinical case.
Thank you, Dr. Farjana. I'm Professor Mohammad Shafiqul Bari. Actually, this patient, Middle East patient, presents with subacute dyspnea, along with background illness of mitral valve prolapse and Hodgkin's lymphoma. So, if we consider the cause of dyspnea here, there are some differentials. That is the heart failure, another is the lung mets, maybe, another is the pleural effusion, which is both caused by heart failure and lymphoma, and other is pericardial effusion. So there are several differential diagnoses of this subacute dyspnea. But bilateral diminished breath sounds points the diagnosis of pleural effusion, which may be both to heart failure due to mitral regurgitation and also maybe due to lymphoma. But key sign is here is the jugular venous distension. This is the key sign. This indicates there is heart failure. So the cause is probably the mitral valve prolapse causing mitral regurgitation, that is causing the heart failure. This. But important distractor here is the lung lesion, which may be due to consolidation, maybe tumor. So this is the confusion here. But management team treated with diuretics and follow-up exercise shows there is nothing, this mess. So this indicates this is a phantom tumor. And sometimes it is called also vanishing tumor or pseudotumor, in which fluid accumulates between the fissure. So the take-home message in this case is, in every cases of heart failure, we should keep phantom tumor in our differential if there is a mass lesion like in the chest X-ray. And we should treat heart failure, and we should also repeat the chest X-ray before doing some costly investigations and invasive diagnostic procedures. This is the key message, I think. Thank you so much for giving me the opportunity.
Thank you so much, Dr. Shafiul Bare. I truly appreciate your expert input. Very much helpful. Now let's focus on
There's
our
one
fifth
thing, Dr.
clinical
Hawk. Dr. Hawk, I
Yes.
wanted to add something. I think we got
Yes,
a
please.
a little more input from Dr. Mir.
Yes, please.
He said that it's common in the elderly patients with pre-existing lung disease and renal impairment, and which is great. Thank you so much for your input. And I think most of the people actually picked the right answer, number 2. I went
So,
back and then kind of like checked.
yeah, just wanted to make a clarification here. He made that comment for the nitrofurantoin-induced lung fibrosis.
Oh, sorry.
Yeah,
Yeah.
in the coroner, in
Okay,
the elderly
it came a
patient,
little late from my
lung
end. Okay, sorry about that.
And I think he had another great comment for the first case, and I wanted to read it.
Right.
And Dr.
Yes,
Faraz, important to realize that angioedema can be of 2 main types: histamine predominant and bradykinin predominant. So the later, which is the type from TPA, tends to not respond well to antihistamine and steroid because it is bradykinin predominant. So ictabant bradykinin inhibitor works better here. So thank you so much for the input, and yes, at the end we'll come to you, and we for all those excellent input. Dr.
Thank you so
Farzana.
much, both. I truly appreciate it. And here I cannot see the chat, so appreciate your understanding and appreciate all of your valuable input. Please keep them coming.
And I think
Now
this is
let's
your last
focus.
case, right?
Yes, you
Yes.
are correct, Dr. Mitra.
Yes. Thank you.
Now let's focus on our fifth clinical case. And as Dr. Mitra mentioned, this is the last case. So for this
There is
case,
one
we have
question. I'm
mixed
sorry.
health.
I'm sorry. There
No
is one
problem. Yes.
question from a participant, Dr. Mehdi Hassan. Is there any relation heart failure with lymphoma?
That's a great point. I do not think so. I think that was the past medical history was highlighted. So as Dr. Shafiqul Bari mentioned, that this vanishing tumor / pseudotumor is mostly with the with the heart failure exacerbation. Anything else, Dr. Ahmed?
In case
No,
of
I think
lymphoma,
that's
if there is a
the
chemotherapy, or chemotherapy can lead to DCM, dilated cardiomyopathy.
like a cardiomyopathy, yeah,
Yeah,
that
yes.
can cause some
So
heart failure.
lymphoma, it can be associated. Then if it's in, you have mentioned that treatment history regarding the lymphoma. So lymphoma can cause dilated
Doxorubicin,
cardiomyopathy.
yes. Mhm.
Got it.
So
Thank you so much for
that's
sharing.
a
Appreciate
very
it.
good point. And I think Dr. Mir raised his hand. Dr. Mir, please.
No, I was going to thank you. I was going to say the same thing. I mean, anthracyclines are commonly used for treating lymphoma, and they can then lead to cardiac dysfunction, heart failure. So it may be that he had radiotherapy and chemotherapy for the lymphoma, which has led to a cardiomyopathy, hence the heart failure. As Professor Azad said, that's probably the link here.
Thank you so much for bringing that up. Great point. Appreciate it. Okay, now let's go back to our fifth case. Mrs. L, she is a 61-year-old female with poorly controlled diabetes. She was admitted for acute hypoxic respiratory failure, and she was also found positive for COVID. She is continuously having headache and mouth pain for the last 3 days. So now you did the mouth exam, and your finding is, so the question is, what is your diagnosis for this patient? So this is the mouth exam, and this is open forum. So please share in the chat that what is your diagnosis coming to mind.
Most of
Dr.
the
Mitra and
people said
Dr. Ahmed.
mucormycosis. Yeah, most
Okay,
of the people,
fantastic.
I think all of them said
Okay,
mucormycosis.
awesome. Thank you. And I cannot see the chat, so I appreciate all the help.
Mhm.
Okay, so yes, you are absolutely right. So this is COVID-19 associated mucormycosis, and as this has been published in the Lancet, that there was like COVID-19 associated mucormycosis almost like from many of the countries. And if you remember just one thing for this case, that is COVID-19 associated mucormycosis. This is a rapidly fatal infection that is spreads from the sinuses retroorbitally to the central nervous system. And it requires emergent surgical debridement in addition to IV antifungals. So very important to collaborate with our surgical colleagues as well to ensure proper treatment for this mucormycosis along with antifungal. Now I will invite our another expert panelist to share their thoughts about this case.
Thank you, Dr. Farzana Haq, giving me opportunity to say about the mucormycosis. 24 years back, I have a case report in our BCPS journal about this
Very nice.
condition. A very fatal disease. Misnomerly, we said that this is a case of black fungal disease, but it is a misnomer. But in this country, this is not uncommon in our country. And during the era of COVID, the mucormycosis prevalence incidence is more common in our country because we are using steroid and we have uncontrolled diabetes is the major risk factors. You perfectly said that the rhinocerebral mucormycosis is the most common clinical type, but there may be pulmonary and also the gastrointestinal mucormycosis, but we are talking about this rhinocerebral mucormycosis, which is usually caused by Rhizopus aereus. But there are many more types of mucor is there. But after the arrival of COVID, the mucormycosis comes to the upper area, that the mucormycosis is the most important cause of fatality associated with COVID, because steroid, because it causes the inflammation, suppress the inflammation, but hyperglycemia in another inflammatory state. And we also said that, see that the iron metabolism is also another important issue for developing more incidence of mucormycosis in COVID-19 patient. So hyperglycemia and other immunosuppressive state potentiate the prevalence of mucormycosis. You rightly said that the team approach is very important because the internist, microbiologist, and perfect diagnosis by histopathologist very important for the diagnosis. But the main focus should be the surgical debridement of the patient, the removal of all the debrides owned, and also there may be involvement of neurologist and ophthalmologist also. So team approach requires number of specialists. So the underlying disease, diabetes control, judicious use of steroid, and finally the addition of antifungal drug. You perfectly said that the IV liposomal amphotericin B is the key for the treatment of mucormycosis. But unfortunately, in our country, this low resource country, we are very much helpless that this type of drug is not usually available in our country and very much expensive for poor people, poor country for us. And we are using, if possible, amphotericin deoxycholate, but it should not be the replacement of liposomal amphotericin B. The another drugs, the isavuconazole or posaconazole, also used in your country, but it is not available in our country. In our country and also the India, they recommend to use the itraconazole, IV itraconazole, but unfortunately, this is also not available in our country. So, for our country to save the patient, we need the IV parenteral antibiotic, antifungal drugs more important. The mortality, the prognosis is very bad. It depends on the delay in the diagnosis. So if we delay the diagnosis, the mortality will be doubled and tripled. So we have to vigilant that the COVID patient, if develop any black uh, uh, scar or black lesion, we should consider that the patient having the mucormycosis and rapid action should be taken. Thank you, Dr. Farzana, and thank you, Dr. Tasbir Bhai and the Chandan, to give me the opportunity to say in your platform. Thank you all.
Thank you so much for bringing this important issue. I truly appreciate, bringing this real world perspective for our country. So I would like to end this session with top 5 key takeaways. First, orolingual angioedema. This is a known potential adverse effect of tissue plasminogen activator. Second, chronic nitrofurantoin-induced lung injury is a rare cause of interstitial lung disease, and this is a diagnosis of exclusion. Third, folate malabsorption can cause cerebral calcification like celiac disease. Fourth, phantom tumor of lung results from localization of pleural effusion with interlobar fissure due to heart failure exacerbation. And finally, mucormycosis requires emergent surgical debridement in addition to IV antifungal. Thank you so much, everyone, for joining, and thank you so much for all the panelists. Truly appreciate all your valuable input.
Thank you so much, Dr. Hogg. Does anyone has any specific question from the participants?
Yes, Dr. Anindita, I have some comments. I just opened up the chat box. So one,
Right.
so first of all, thank you, Dr. Farzana Haq, for awesome presentation. I think the cases were really great, and I really appreciate all the panelists for their active engagement and some valuable discussions. And I do see some good points here. So one of the point, Dr. Azizul Haq, he mentioned, other risk factors for developing mucormycosis are neutropenia due to cancer treatment, hematopoietic, and solid organ transplantation, diabetes mellitus in particularly when presenting with ketoacidosis, he made another great comment. I have to go back. For the heart failure patient, that doxorubicin used to treat lymphoma can cause cardiotoxicity. I think that's a great point.
Great point.
That's a great point. Then Professor Azad, he also mentioned that posiconazole is available. I treated 2 patients with good response. I think that's great. That's great. And
Very nice.
yeah, and I think those are the great comments. Now, I think I'm not sure Tasbir Bhai is still here, but at the beginning I forget to introduce him. But I think for the PHA, he is the man behind the PHA, and that is his vision. And
Okay.
Professor Tasbirul Islam doesn't need any introduction. Now, I would go to Dr. Fraz Mir for his comments, overall comments about any particular case or any specific for this presentation. Dr. Fraz Mir.
Well, thank you, Dr. Mitra. I mean, I think, to be honest, I've made my comments in the chat as we've gone along. I think there were great cases, Dr. Huck, so thank you for sharing those. I mean, the second case with the celiac, I've never seen such profound calcification. That's quite amazing. And I think the mechanisms are interesting, aren't they? So often with CEC, often they say that, gluten-free diet is the key point here. And I think that needs to be reinforced, because if you see that, then actually the treatment is, yes, anti-epileptics, but also a very strong adherence or strict adherence to gluten-free diet. I think the angioedema case was also interesting. As I mentioned, with TPA, it tends to not respond terribly well to antihistamines and steroids. You can use adrenaline in extremis, but actually things like icatibant might be better, and actually just supportive care may be all that's required. With nitrofurantoin, I mentioned that it's generally more common in elderly people, but also those with renal impairment or those with pre-existing lung disease. If they have pre-existing fibrosis or they have pre-existing COPD even, then they are more at risk. With the phantom lung tumor, you tend to see it more commonly, I think, on the right lung, because of course you have 3 lobes and you have an extra horizontal fissure, which means that you may act as a focus for the loculation of the effusion. So you might see it more on the right side. So that's quite common. I mean, mucormycosis, thankfully, is not something we see very much in the United Kingdom. I mean, I think I saw 1 case, but that was when I was in India. And I don't think that person, I'm afraid, did very well, because often they present quite late, as you said. And the risk factors, as you said, are things like steroids, poor diabetes control. Also, this curious link with iron overload. So if you have high levels of iron, the fungi seem to like that. So it's probably best to try and avoid iron supplementation at that point, and certainly parenteral iron is probably not a good idea. But also, the actual COVID virus seems to make them more at risk of getting it, because it sort of messes around with the immune system. And I think other people, I think Professor Azad mentioned that any type of immunosuppression may put you at risk of this devastating condition. So I've learned lots as well myself. I found it quite educational, and thank you for providing the cases, Dr. Huck. So yeah, that was great.
Thank you so much. Truly appreciate it.
Thank you, Dr. Fraz Mir. And before I would now like to invite Professor Rubina Yasmin to make the concluding remarks as a chairperson. And currently, with her position, she is also the guiding force of medical education in Bangladesh as well. And I want to specially thank all the panelists and Dr. Anindita Ahmed to co-moderate with me. Thank you, Anindita. Dr. Yasmin, Rubina Yasmin, to you.
Thank you. Thank you, Dr. Chandan. It's my great pleasure to be here as the chairperson of this session. It's a very learning session to me also. First of all, I'd like to congratulate Dr. Farzana for her nice presentation in a different way. I also want to say thanks to all the panel of expert present here, including Fraz Mir and Dr. Tazveer. And lastly, I want to thank all the intern all the trainee doctor of different part of the Bangladesh who are joining here. Regarding the different case, I am very much impressed regarding the presentation of Farzana, because the first case that was TPA-induced angioedema, though TPA-induced angioedema is not common to us as internists, we usually do not use TPA in our setup, because TPA is usually used by neurologists in their setup. But still, the presentation of orolingual swelling, many of our trainee diagnose the case as weakness of the 12 nerve palsy. So it's they give wrong answer to this, as this is not common, as I have never seen this type of case. So I think our trainee doctor also did not go through the case, but it's a good presentation. High index of suspicion is required, as this case can be turned into a fatal outcome. So early diagnosis is required to save the life of the patient. As the stroke patient had also neurological deficit in tongue, in lingual area. So high index of suspicion is very much keen for a physician to diagnose the case. And the management, as mentioned by Mir Faraz, that anti-bradykinin inhibitor is required to control the angioedema. And regarding the second case, in this case also high index of suspicion is very much keen to diagnose the case, because CT scan is not a common investigation in case of celiac disease. And in case of celiac disease, the CEC syndrome is manifested as extra-intestinal manifestation of celiac disease, though it is not very common, but it can happen. And the early diagnosis and early management is very pertinent to prevent the neurological damage of the cases. So it's I again thank Dr. Farzana to present such an important case, because it is probably it is not very much known to all our trainee doctor. It will be very much helpful for our trainee doctor. And regarding as Professor Azad also mentioned, he gave his much important input regarding the CEC syndrome. And regarding the third case, the nitrofurantoin-induced chronic lung injury, that patient presented in the form of DPD, or idiopathic pulmonary fibrosis. In that case, again, the importance of history taking. If anyone ignored the history or missed the history of long-term nitrofurantoin intake due to prophylaxis of urinary tract infection, in that case, the patient may not be diagnosed properly, as treatment is very simple: discontinuation of nitrofurantoin and never started nitrofurantoin. So history taking, this is a key information for our trainee doctor, those are attending today, that history taking is an important part of the clinical diagnosis. And the history of drug history is also very much important, that patient may forget that she is taking nitrofurantoin for last 5 months, as the dose was very low dose. That patient may be ignored the history. So the important part of the clinical diagnosis is the history taking. So message for our trainee doctors. And regarding the fourth cases, it's an important case. It's an interesting case. Rather, I say it's an interesting case. Uncommon presentation of common disease, bilateral pleural effusion in case of heart failure or any other disease, in case of lymphoma or any other cause of bilateral pleural effusion, is very much common in our practice. In many almost in every hospital there was bilateral pleural effusion, but there in the form of phantom tumor, in the form of loculated pleural effusion in interlobar fissure. It's we learned it in our book, but I never saw this type of case. The X-ray is very interesting. Thanks, Farzana, for sharing this interesting X-ray. And the treatment is very much simple. Thus, IV diuretics can resolve the problem. But though there may be differentials of this case, there may be need of pleural fluid aspiration and analysis of pleural fluid as this patient had history of lymphoma. That's different thing, but the diagnosis is whether it can be a case of interlobar loculated diffusion. The suspicious index of suspicious should be very high in that case. Thank you again for such a nice case. And regarding the last one, mucormycosis, during the COVID period in our country, I was working at that time in Mugda Medical College Hospital. That was a COVID dedicated hospital. And we have gone through many COVID cases at that time. And there was mucormycosis was not a rare in our setup. We have gone through 4 to 5 cases of mucormycosis at that time. And as mentioned by Farzana, that multidisciplinary approach is very much necessary in that case, as surgical debridement, surgical excision is required. And the treatment outcome is not so bad by antifungal treatment, though Professor Aziz mentioned that posaconazole is available, and it is known to me that posaconazole is available in our country in some cases, but injectable other antifungal can give a good solution of the cases. And last of all, I again want to thank Dr. Farzana for a nice way of presentation. Definitely, it's a very interesting session because the presentation is completely different from other presentation. The short symptoms and the key messages and evidence-based messages. I think our trainee will be very much benefited through this session. And personally, I am also very much benefited through this session. I again grateful to the organizer for giving me the opportunity to learn much things through this program. And again, thanks to all. Assalamu alaikum.
Walaikum assalam. Thank you so much, Dr. Yasmin. Thank you so much for all your input. And I see Dr. Tasbirul Islam is back. Tasbir Bhai, can you say something to everybody?
No, assalamu alaikum, Anindita. Actually, I listen all the conversation, all the presentation. It is a great presentation. And so many familiar faces today. So nothing to add, just only as the intensivist for the first case, we see, I just recently, a week ago, I saw TNK, tenecteplase related angioedema, and that responded to the steroid and histamine. I totally agree. If it's bradykinin related, normally it doesn't work. We have to use icatibant or ecallantide. But, it's very expensive. That's why I said, you can use FFP and TXA, because TX is a plasmin activation inhibitors, and also the FFP you can use instead of icatibant and the ecallantide. That's number one. Number two is try not to use the epinephrine if it is TNK or the TPA-related angioedema, because you don't want the blood pressure to go up, because you just give the TNK or TPA or the TNK, because you want to keep the blood pressure below 185 or below 180. And a third important thing, if the patient got angioedema during the TPA infusion, just stop the TPA infusion at that time rather than continuing the TPA infusion. So that's, and always alert the ICU team and HDU team, because they are dealing with the airway. So it's very important to alert them and probably may need at least HDU admission for monitoring. So thank you so much. Really great presentation. I want to thank everyone on behalf of PHA, and hopefully we'll do more and more this kind of session. And thanks, Farjana, for a brilliant presentation.
Thank you, Dr. Islam. And again, thank you all the participants too, because without your participation, and it was a very interactive, presentation, everybody did great. Thank you so much thank you so much to all the panelists, Dr. Chandan Mitra for inviting me to be to co-host the event. And as usual, Dr. Haq, it was a great presentation. Thank you all and have a good night.
Thank you. Good night.
Lastly, I want to thank Dr. Chandan. Thank you very much for giving me the
Chandan, bye.
opportunity. Thank you very much.
Thank
Thank
you.
you, everyone. Thank you, Dr. Fraz. It's
Bye-bye.
nice
Thank
meeting
you.
with
Thank
you and
you.
nice connecting with you. And we'll stay connected.
Thank
Of
you.
course.